The broadcast is now starting. All attendees are in listen-only mode.
Hello, and welcome to the New York State Care Management Training Initiative. My name is Nicole Kadovius, Director of Practice Improvement for the National Council on Behavioral Health, a partner with NIAPRIS on this project. The National Council is a behavioral health organization with over 2,900 member organizations serving over 10 million adults, children, and families living with mental health and addiction. As an association, we advocate for policy to ensure that individuals have access to comprehensive evidence-based healthcare services. And our practice improvement team provides state-of-the-science education and practice improvement resources. I'm excited to serve as your moderator today, as Ruth Cullen-Wagner is currently on another assignment. She sends her regards, and we are all very excited. The training is almost at its end. We will discuss more of that at the end of today's presentation. Next slide, please. NIAPRIS is very proud to be working with our partners on this initiative, with New York State Council for Community Behavioral Health, New York Care Coordination Program, the Center for Practice Innovations, the Coalition of Behavioral Health, and the National Council. Today, we are excited to have Jeff Capobianco from the National Council with us, and I will introduce Jeff in just a moment. As usual, we just want to go through some of the information on the slide below that may be familiar for you, but just as a reminder, if you're watching as a group, please list everyone's name at the end of today's webinar. There is an evaluation at the end. Evaluations are asked of everyone, and they are required if you would like to have your CEUs. If you miss a training, you also have the opportunity to access this training or those that you've missed via the link that's on the screen. And just as a reminder, we will record your attendance at each event, live or recorded. So if you miss one, we'll still record your attendance and contact you and your supervisor with links to any webinars that you haven't seen. And October Regional Office Hours is our last activity. CEUs, Continuing Education for Social Work, CPRP, and CRCC is a total of 10 hours to everyone who completes this series. And LMHC began with the series in August, and it does go to the end of the training series with 3 hours. We will be having 3 polls throughout this presentation, and we encourage you to please participate. It's really great to hear feedback from the audience as we're going through the presentation, and also encourage you to use the question box so that you can type your questions. We'll be monitoring throughout the webinar, and I'll either integrate with Jeff the questions during his presentation or save them to the end, and we will try to get to as many questions as possible. And next slide, please. Today's presenter, it is my honor to introduce my colleague, Dr. Jeff Capobianco, to you as today's speaker. He has over 26 years of clinical, administrative, and healthcare research experience. He also has an extensive background in designing and implementing primary, substance use disorder, and mental health care integration models for children and adults. With expertise in evidence-based practice implementation, Lean Six Sigma methodologies, and learning community approaches to organizational change, his focus on developing sustainable, efficient, and effective clinical, financial, and quality approaches to healthcare integration. Prior to joining the National Council for Behavioral Health, where he is a senior consultant, he held positions as a research investigator at the University of Michigan School of Social Work, where he continues to teach part-time as the Director of Research and New Program Development for Behavioral Health Managed Care Organizations. A master's level licensed clinical psychologist in the state of Michigan, he received a doctorate of philosophy degree from Wayne State University in program evaluation with a focus on quantitative methods. He has consulted with dozens of healthcare organizations across the country, including state departments of Medicaid, hospital systems, and county health departments. And Jeff is just a tremendous speaker. Really honored to welcome him today. And Jeff, I will turn it over to you.
Thank you, Nicole. No pressure. I'm happy to be here today. Want to have a conversation with you all. So I'm hoping folks will have questions, ideas, things to share, tips they've learned, and please type those into the chat box to the right throughout the presentation. I'll take questions throughout the presentation or comments. The agenda is pretty straightforward, although it's a lot of content. So you'll hear me speaking quickly, and if you miss anything, please just ask me to repeat things as we go. Towards the end, we'll have some poll questions and time for discussion. And as I mentioned, I'm interested in tips and tricks that you've all learned with this topic of care transitions. So I'll be talking about care transitions within the context of care pathways, which I'll describe in detail. And we're really going to be focusing on how do you do this, what works, what doesn't work, and giving you the time in this webinar to kind of remove yourself from your daily work to reflect on what the job is that you and your staff have, because it's a really big one. The work we do in healthcare is pretty unique. It's similar to work that's done in education, but very different than most other types of work you see in any marketplace. And what makes it particularly interesting, but also I think difficult, is the fact that we simply cannot change people. People come to us and they want to be relieved of pain. They want information. They want to change. They want information that will allow them to have different health behaviors or feel better, or a combination thereof. And we simply can't just magically change people. However, that is our job, to change people. So the people we serve are our product. We are in the business of improving people's health, but we can't do that without their input, without their buy-in, without their perspective, without a relationship, essentially. If you're going to go to Best Buy and get a computer, you don't develop a relationship with that computer. If you come to healthcare, if you go into education, the relationship is one of the, if not the strongest component of the care you receive. So that's a complex thing. It's not easily measured, and some would say it's very artistic in what you do in healthcare to engage people towards health and to help them see the future they have for themselves in the form of recovery or health. Since that's not easily measured, since that is unique to each person, everything we do around that relationship building and that relationship we have with the patient, in my opinion, needs to be structured in such a way that allows the clinician to spend the time in that space to do the best job that they can. And if they're distracted by how to bill for things, how to do documentation, how the team works, what their job is in relation to another colleagues, all of that variability, all of that, for lack of a better term, noise in the care space interrupts their ability to develop this relationship and to help the person really achieve their goals. Another thing that makes our job particularly difficult, and we've experienced this in the safety net healthcare arena for decades, it's becoming more prevalent in the primary care non-safety net healthcare system, hospital-based system, this notion of social determinants of health. So not only are we helping people with their mental health, their substance use, their physical health, but we're also having to help them with things like their social networks and developing those, their financial health, their housing, their education. So all of these factors play a big role in whether someone's health behavior is going to change in the direction of them becoming healthier. If they obviously don't have housing or they don't have food, it's going to be hard to kind of work with us around changing their health behavior. So this adds another layer of complexity that is very hard to manage. And the people that you serve, as you very well know, come with multiple health conditions and multiple social determinant needs. So in my opinion, it's incumbent upon us to design a system that's going to make people's jobs easier so they can actually develop these relationships and execute on providing healthcare, but also make it clear to the client or the consumer about what we're doing with them to promote health literacy. If you look at this logic model here, this is essentially kind of a 10,000-foot view of what you all are asked to do every day. And on the left-hand side, we've got a client who comes in, happens to be a woman who's substance involved with nicotine, estranged from her natural supports. She has depression, she's homeless, she's unemployed. So here's a person with multiple needs. And an interesting thing about working in behavioral health is sometimes people show up and they really don't know what they need, or they don't think they need anything. They come because somebody else told them to, or they're required to. So that makes it even more difficult, as you know. So we've got this person presenting. If we go to the other side of this logic model to the far right, these are the parameters or the targets we typically, for this person, would develop to help them achieve their goals. And these would be their goals. If they could hit these targets, if they could achieve these things, both she and I as a provider would be happy. In the middle is everything else we do, which includes assessing their level of engagement, certainly, to make sure that we understand what their intentions are as it relates to each one of their social determinant needs and each one of their healthcare needs, because they can have different levels of engagement for each of those. They could be quite activated to get housing, but not activated at all to stop smoking. And then we design a level of service that's going to meet that person's need, and that costs a certain amount of money. We've developed that service array for them, and we put it into a service bundle or a person-centered plan that clearly articulates, what they're going to do, what we're going to do, includes crisis plan, includes all these components. And then to some extent, we think about how long this person might be in care, and we move them up and down in care based on whether they're getting better or not within a time period that both they and I think is reasonable. This idea of length of care and time to treatment or time to hitting your treatment targets is not something we do very much, but is something that is coming in the healthcare field in the form of episodes of care. So it's something to keep in mind as we think about care pathways and how we design them. So essentially, this is the job we're all asked to do, and it's considerable. Care transitions and people moving in and out of care from one level to another is a big component of this, which we're going to talk about. So if we get down to a 5,000-foot view, this is essentially what I'm describing here. And we do our screening and our assessment, we develop our treatment plan, and what is obvious in the healthcare literature today, and if you talk with organizations that are very high performing, meaning they're able to come in on time, on cost, and on treatment targets, this interdisciplinary team component is really critical. And this is the notion of team-based care and the ability for teams to come together around a client and look at the treatment plan, engage with that client, and see, are they getting better or not? And not only for individual clients, but to be able to scale that up across caseloads, across populations of people with different health conditions or people with different sexual orientations or races. This is this notion of population health management, where we're able to drill down to one client and then scale up to multiple clients and see if people are getting better or not. And if they're not, to change how we're providing that care. Within this team-based model, we're also doing our care coordination, which includes care transitions, which we'll talk about in just a minute. So this idea of the team coming together, stratifying risk, which is a component of population health management, stepping people up to care who are at risk, stepping people down to care who are getting better, or keeping people where they are if it looks like they're achieving their targets or they're well on their way. So there's a couple terms I want to unpack as we move into a discussion about care transitions within a care pathway. And first I want to talk about care management just briefly. This is this notion of an umbrella term. This is everything we do. Care management includes, the logic model I just showed. It's the screening, it's the assigning people a level of care, it's our team meetings, it's the medication we provide, it's the therapy we provide, it's the way we risk stratify people, moving them up and down in levels of care. And it involves our care coordination, which importantly includes managing transitions of care. So if we use this term care management as an umbrella term, everything underneath it is the work we do every day. And if we look specifically at care coordination versus care transitions, what we see, and I think you've probably all talked about this, is the fact that care coordination is a term that includes care transitions. And care transitions are very specific, measurable changes that people make as they're receiving care. And it's a movement of a client from one provider to another. So it's this idea that we're working with somebody as they move within our health system and getting the support they need. So it could be a transition from a group home to their own independent apartment. It could be transition from the hospital back out into the community. It could mean transition from the community into the hospital. And this can take many forms. You can have transitions of care within your organization where someone transitions from assertive community treatment to moderate intensity case management. Or, as I mentioned, between hospital settings. You can also think of it as people moving between health states as it relates to the care they're going to be receiving. So this is the notion of, moving from a palliative care where we're looking to help someone with an illness that's likely to be terminal to moving to hospice, where we've decided, yes, this is terminal. We're gonna help the person through the process of dying. So this notion of transitions of care takes many forms. And as I mentioned at the top of this presentation, if our jobs are going to be made easier and effective, we have to be able to standardize things like this so that we can spend the time keeping that relationship alive, developing that relationship with our clients. And care transitions or transitions of care are definitely something that we can standardize within the care pathway. Quickly, I'll just talk a little bit about population health management risk stratification, because this is something I'm going to talk about when we unpack care pathways. So population health management, as I described before, is this notion that today, although you might not love your electronic health record, we do have a lot more data as a result of our electronic health records than we've had in the past. 10 years ago, we weren't able to really do effective population health management, which means we can bring together relatively large sets of data and have that data tell us the story about how well we're doing in providing care to the folks we serve. So it's this notion that we now have the ability to pull data and proactively look at how individual consumers are doing or groups of consumers are doing. We could say, how are all of our patients who are depressed doing? Are they getting better or not based on their PHQ-9 scores improving over time? How are we doing with transitions of care? For all the people that were admitted to the hospital, did we have a coordinated discharge from the hospital to the community or not? Did we have the treat to target or the metrics for care transitions achieved that we established for ourselves? Risk stratification, as I mentioned before, oftentimes we think of risk stratification as this managed care thing that has to do with cost, and that is true. Managed care does look at risk stratification from the perspective of cost and whether people are going to become more expensive or not. In the care pathway, we definitely want to look at that, especially if you're a CCBHC or you're a provider that has a value-based contract that's capitated, or you have a per member per month rate. If you're over billing that rate, you're going to blow past your monthly rate, and that's one form of risk. Other risks, which we'll focus on here, have to do with the clinical risks. Are people clinically looking worse? Are they on their way to decompensation, and can we catch that early? Or are they doing really well and we need, to step them down in care and provide less or different types of services to them so that they can continue their path to hitting their treat to target or their recovery outcomes. So big job, as I mentioned at the beginning, and all of what I just went through, I think clearly describes the work you all do and the difficulty in doing this. But how do we do it? And we propose this notion of a care pathway. In the literature recently, we've seen some discussion, primarily in the substance misuse literature, around this notion of cascades of care. But it's this idea that we have the opportunity as healthcare providers to standardize how we provide care to the best of our ability. Certainly, as I mentioned before, there's some things you just can't standardize, and you really don't want to spend a lot of time standardizing those things. You know, the engagement process, we can standardize the steps to meet with people, but what happens, you know, in that space when you're developing a relationship really is special, and it's something that we want to give staff time to be able to do effectively. The care pathway allows us to be able to do that, so we can protocol or standardize all the administrative workflow steps, so billing, documentation, and the clinical steps, how we gather information, how we provide a behavioral health intervention, how we prescribe meds, provide cognitive behavioral therapy, or provide supports. So this care pathway allows us to operationalize that into steps that are replicable and teachable, so that we can say, this is how we treat depression, this is how we do care transitions. And we can use it to tell our funders and our accreditors how we do things. And I think most importantly, we can use it to test out if our way of doing our work is effective or not. If you standardize how you do your work, you can actually hypothesize why you're not hitting your targets or not. If you standardize how to treat depression and everybody you treat for depression isn't getting better, then the standardization allows you to do some experiments, some testable hypotheses to say, well, what if we did this differently? Would that make a change? And you try it out. You do a rapid cycle around it and say, yeah, it improved. Our outcomes are better. So you've learned something. You've learned a new way to do your work. If things aren't standardized and people are coming to work every day and kind of doing what they want to within a loose framework, it's going to be a lot harder to know why you're not getting the outcomes that you want as an organization or as an individual clinician. Care transitions is a big piece of this in any care pathway, and as we'll describe, care transitions exist in all of your pathways. So if you're doing a pathway to help someone get housing, there's going to be a care transition component to it. We're going to use the example of depression today, but if you're treating someone for depression, there's going to be care transitions components within that pathway. So the nice thing about focusing on something like care transitions within your pathway is once you get it done, once you've developed your protocols and you've kind of mapped out what it looks like, it's easy to walk it over to other health conditions. So if you're looking at hospital care transitions for depression, it's going to be very similar to how you do hospital care transitions for someone who's admitted for their schizophrenia illness. So there's a lot of bang for your buck that you can get by focusing on care transitions, which we'll talk about. A good care pathway, as I mentioned before, allows for really good customer engagement and the use of trauma-informed care, motivational interviewing. It standardizes how you do your screening assessment and your team meetings and how you do population health management. It standardizes who does what in the workflow so that every team member knows where their job ends and somebody else's job begins and where the jobs overlap. So either staff could do it potentially, but it's usually best done, you know, this way. A lot of staff, if you talk with them and ask them what their job is, they'll tell you pretty quickly. And then if you ask them, well, what is your coworker's job? You're a peer, you're a case manager, they're a therapist. What do they do? A lot of times what staff describe their coworkers do is not what that coworker thinks they do. And that's a problem because that means there's variability within your care pathways because people are doing different things or have different understandings of what they do. Good care pathways help standardize that. And as I mentioned before, it allows for you to do quality improvement activities that are structured and actually tell you in a measurable way whether, you know, your improvements are working or not. I've hit on these. I think, you know, care pathways provide, you know, a clear map for people to reduce variation in how they do their work every day. They're built on evidence-based practices, as we'll talk about, and they really give staff the space to do the part of the job that they typically like best, which is engaging with clients around their unique experience of their illness and how they're going to work through it. A good care pathway has standardized protocols, really clear terms. So if we're using terms like transitions of care, care coordination, population health management, that there's a glossary that explains what those terms actually mean. Definitions of words are really, really important in complex situations like the work you guys do every day. If staff have a different understanding of what a care transition from the hospital looks like, what it is, they have a different understanding of what the team meeting is for, there will be variability and confusion within your care pathways, and therefore you're going to have waste. So to the extent you can, you want to start defining terms and putting those terms in your protocols with definitions. Does this mean you have to spend hours and hours writing up protocols that are long and involved and have very small font? No, that would not be a good idea, and we'll describe, the best way to develop those protocols in just a minute. Good care pathways also have people responsible for monitoring them. That should be your supervisors who are monitoring fidelity to whatever protocols you've designed for your care pathway. So if you've designed a protocol for transitions of care from the hospital and it's not being followed by staff, that's a problem, and that's something for discussion in the team meetings and during your supervision. And it's really the supervisor's job to ensure that all staff are following through with what they committed to do in the protocols that were developed for the care pathway. And it doesn't have to be a difficult conversation. I mean, sometimes staff find better ways to do stuff, and they say, no, I didn't do it that way because I think our protocol's not good. I did it this way, and it's more efficient. You say, good job. Let's make that our new protocol then. So there's a quality improvement aspect always to any of the tension that's created by teams, not following protocol or, thinking differently about how their job is done every day. So any questions before I jump into the steps here, Nicole? Anything coming through?
Nope, not yet.
Cool. I mentioned I'd talk quickly, and I do. I apologize
for
that.
Yeah, no, you're doing good. I mean, do we want to pause for like 30 seconds and see if anyone has a question that you'd like to type in the box? We'll give you
do that.
20 more seconds, maybe.
Yeah. Please go ahead and type in any ideas folks have.
So a question came in that says, what should we do when walk-ins are closed?
When walk-ins are closed?
Yes.
So somebody walks in and they're a former client that's been closed to the agency.
Tim, can you please elaborate on your question? See if he adds anything to that.
And I could just run with my interpretation.
Oh, Dr. Office walk-in. Dr. Office walk-in. So Tim, are you saying that someone walks in and there's just no appointment available for them, or as opposed to the ER? So what should we do when walk-ins are closed, and do you have a care pathway already made that you can share?
So we do have care pathways that we can share around a lot of health conditions, and I'll send you a link to a nice website in Britain, actually, that has a bunch of care pathways that have been designed. When it comes to people walking into the front door, having a really robust front end, for lack of better terms, protocols for dealing with different situations is very important. So if people are, stepping down from the hospital and showing up with their My Belongings bag, and you go, boy, were you just in the hospital and nobody knew it? That's a scenario that's quite common, unfortunately. And there should be a way to react to that. Does it have to be protocoled out? Maybe, maybe not. We'll talk about that. But oftentimes the place to start, and I think Tim is onto something here, when designing a care pathway, is to talk with the team about what they're struggling with the most. Where is the most variability in the work they do every day. And that might be someone walking in looking for an appointment that's closed. You know, what do we do with this person? Do we just immediately open them? Do we have to go through the original opening procedures just like if they were a new client? If that is a point of tension in your service delivery, then it's worth mapping it out and spending the time to protocol it out so that you can give it a try, give the best solution to that a try that the team comes up with. And if it works, then that becomes a standard operating protocol or standard operating procedure that your clinic would adopt.
Right. I love that advice. Tim had followed up with that just a little bit more on his question, is that their walk-in does have set hours. So I think that, you know, the approach that you just described would be perfect, you know, in working with your team and looking at identifying when that happens and how to address that. There's another question, Jeff. Oh, sorry, go ahead. Let me give you a second to react to that comment.
Yeah, all I would have to say is, you know, everyone on this webinar has done a lot of work in this field, and they already have care pathways both in their head and with their teams. And most of those care pathways work really well. I'm not calling any of that into question. What I'm calling into question is, can we make it easier on ourselves by beginning to really standardize these things and taking advantage of the technologies we have, like our EMRs, to pull data and get another perspective on what we're doing, which I'll talk about in just a minute.
I love that point, but also the point that you made earlier about having each team member truly understand what their colleagues' roles are and what an important part of the team they play. So it all the pieces together, you know, like what you're talking about, the standardization and really that understanding. And I think that's really great advice. There's a question around engagement, and I don't know if I should hold that for later in the presentation or if you'd like to address it now.
No, let's take it now.
Now? Okay, great. So what are some techniques to use when working with someone who has multiple diagnoses and is homeless? Often it can be difficult to find them and keep them engaged.
Yeah, and that's the piece where having as much of your workflows as a clinician or as a staff person standardized will give you the space and the time to do that, because that really comes down to the art of doing clinical work, where you have to identify, using trauma-informed techniques, using motivational interviewing techniques, you have to find out where this person's motivations are, what they really want out of their life. And it might be something that has nothing to do on the surface with their health condition or the fact that they're homeless. You know, they might want, you know, a girlfriend, they might want a car, and finding a way to link those wants with their current state and the condition that they're in today, which is probably why they're suffering or why they're reporting their needs, making those links between current state and what they want for their future state and helping them get there. Tracking people down. The interesting thing about care pathways for social determinant needs is many of them are for lack of better terms, they're context-based. So they have to do with your community and what's available for homelessness in your community. So a care pathway on getting someone housed is going to include how you engage that person, how you assess for their homelessness, but it's also going to include whatever resources are available in your community. There is best practice around housing people, moving people from homelessness to housing. So you'd pull from that literature, but a lot of the actual practical things you're going to be able to do with that person have to do with what resources are available in your community for people who are homeless. So if you have a rich, you know, community, there might be a homeless shelter that's been funded. There might be lots of supports. If you're in a more rural area that doesn't have as much funding for that, there might not be a lot of services. The care pathway really defines what's available for that person. I worked with a team in Detroit. They had 63 care pathways set up. Over time, it took them a couple of years to develop them, but they had a menu that clients would get when they'd come in, and the clinician would say, all right, you're homeless. This is what we can do This is how we work with people who are homeless. Let's talk about what your options are based on what we can do for you. And in that discussion, it did talk about how to be in contact with that person since they don't have a cell phone or they don't have an address. All the steps that, you know, is the best case scenario for helping that person who's homeless, and kind of mapping those out. So that's what we're talking about here. And again, this stuff takes time. It's not necessarily easy, and we'll talk about in a minute how to begin doing this if you haven't started to really unpack all the care pathways that you're currently engaged in into a standardized way.
Awesome. And Christine, who asked that question, said thank you, responding on the questions. And if you have time for just one more before we continue.
Yeah.
This one is, it's a question around if you have a client that you're supporting that has breathing problems, but they have no choice but to go to the ER, just any ideas that you have around how to best support them.
Yeah, what we'll see here is for care transitions, in the larger term of care coordination, there are essentially three people who are responsible, or three groups that are responsible for care coordination: the healthcare provider, the natural supports, and the client themselves. Everybody has a role in care coordination, and everybody needs to know what their role is. Oftentimes, where those three roles come together and where it's clearly defined is in the person-centered plan, but more specifically, the crisis plan. So crisis plans are critical for patients like yours, and I'll use the term client, patient, consumer differently, just whatever pops in my head, because that's going to be the plan, that's going to be the care pathway for their respiratory illness. So they've got a respiratory illness or disease. You're a behavioral health provider. You're not a respiratory therapist. You're not a pulmonologist, but you are in contact with their primary care who is working with those specialty providers, or maybe you're directly in contact with a specialty provider because this person's getting most of their care through a pulmonologist. That would be the place where you develop that crisis plan, and you map out to the best of your ability what's going to happen when they are in a respiratory crisis. What does it look like? What does it look like when it's about to happen? So you can get this notion of prevention and stepping someone up to care before they get really sick, so that you can reduce their suffering and reduce the cost, so that they know, you know, their air tank's going to be running out and they have no way of getting another one, who to call, so that they don't end up with no air and then end up in the ER. So these are the best laid plans, and you map them out. And, you know, if you've done this work for a while, you realize sometimes plans don't work at all, or sometimes clients don't even engage in the plan. You know, hey, we had this plan. Oh, I totally forgot, you know, and that happens. But that doesn't mean you don't put a plan together. So having the crisis plan embedded within your person-centered plan really is the key. And the crisis plan has to clearly describe, has to have a component in there that's clearly articulating what you're going to do with care transitions that are going to happen for this person if they run into issues with their symptoms or with their social determinant needs.
Thank you so much. And I do have another question, and I think that there may be a similar answer to the one that you just responded to. But this person's asking if you have a suggestion. They have a client that continues to overutilize the ER, and there is no real reason for the visit. It's usually done after work hours, and she says it's constant. If you have any recommendations.
So, and we'll talk about this with EDs in hospitals. So as you guys know, you can't, if a client or anyone, you or I, found a solution to their anxiety, their pain, their need for social supports, or their need for coffee, frankly. Used to work in an ED, and we had a nice coffee machine that was free, and we'd have clients going there all the time. And then as they hung out and drank coffee, they start to not feel well and want to talk to a nurse and want to get admitted to the ED to, get help for something. And they probably wouldn't have needed that if they weren't in the ED. So there is a solution that this person's come up with, which involves the emergency room. And talking with that person around what the emergency room does for them is really important, because you can't remove the emergency room unless you replace it with something as good or something that is going to have an outcome that's going to address that whatever need that's being met. Now, sometimes people will refuse any alternative to the ER. They'll say, nope, I don't like any of the things you gave me. I'm going to keep going to the ER. That's why it's important that the client, the ER, and if they have any social supports, are involved in the plan around what they do when they go to the emergency room, and that the emergency room is very involved in that, so that the message is crystal clear to everybody as to what the plan is when this person goes to the ER, or more importantly, when they feel like they want to go to the ER and need to go to the ER. Now, the best laid plans, don't always work, and sometimes the ERs aren't even willing to talk with us about this client who keeps going, because frankly, they're either too busy or they're okay because that person has insurance and they can bill that insurance when they go to the ER. So things get complicated. I think professional persistence is always the key, and we'll talk about this a little bit with hospitals that aren't willing to, meet with you all around engaging around development of crisis plans, or even engaging around a care pathway that has a standardized protocol for what you do when a client shows up there. But that's a good example.
Thank you, Jeff. Yeah, that's really great advice. And I'm just trying to be mindful of time. It's 10:43, so I'm going to hold questions and let you continue, because I know you have a lot of great content.
Yeah, and I'll keep going and talk quickly. So
okay.
10 steps to care pathways. Don't be scared off by the 10 steps. I could have made it 3 steps, but the reason why we have 10 steps is just to make it a little bit more clear, and many of the steps can be done really quickly. So don't feel like this is a huge lift. The hardest part of this is going to be steps 6 and 7, which we'll get to. So let's choose depression as a, see if my screen is working here, as our clinical condition, because depression is relatively clear on how you treat it. We have validated screening tools that are relatively easy to use. But we could pick any clinical condition or social determinant need. To find the population, we're going to pick adults diagnosed with depression. We suggest you pick pediatric or adult populations to start, and then you can refine the population by saying African American adults, or adults who have different sexual orientations or have different language needs. You can begin to refine your care pathway to meet the needs of these different populations. But for here, to keep it simple, we'll say adults diagnosed with depression. You convene your interdisciplinary team. This could be a quality improvement team that's really going to spend a lot of time building out this care pathway. Or if you don't have time for that and you're not interested in a giant quality improvement initiative, then pick your assertive community treatment team, or your moderate intensity team, or your access team. That would be your interdisciplinary team that's going to work on this care pathway. Many of you make up that team and are on this call. So the first 3 steps are already done. Step 4 is defining your targets. Now, this is really critical, and many times people get a little overwhelmed by this. My suggestion when it comes to choosing the targets for your care pathway, those treat to targets that you're shooting for, is to start really simple. Start with maybe 1 to 3 metrics that you want to start tracking, because you don't want to get overwhelmed, and sometimes it's hard enough to get IT to give you some metrics around one thing, let alone a whole bunch of them. So step 4 is looking at the metrics that you're going to measure to track your condition, whether it be a social determinant need or depression. So for depression, there's some usual suspects when it comes to metrics you're going to want to track. And these are the metrics the team is going to use to do population health management, right? So number of clients screened, you're going to want to screen, 100% of the people coming through your front door, unless you know that they don't need to be screened because they have another, condition that you don't screen depression for. Maybe they've got schizoaffective disorder, bipolar disorder, and you're going to use another screener for that. So essentially, this is your front door screening. Then for people who screen positive, did they get follow-up care? And for people who did get follow-up care, do they get better over time? This is really critical for us. Many times organizations do a great job of screening folks, but then you ask them, well, are people getting better? And they go, oh, I don't know. We just put the data in there. We don't really look at it over time. And the reason for that is it's hard. It's hard to get the data out. It's hard as a team to sit down and look at them. But it's immensely effective in doing that. It makes your jobs a lot easier if you get there. Now, when it comes to dashboarding it, if you don't have an EMR that works well, or your IT people say, yeah, we'll throw it on the pile of to-dos and get to you next year, there are dashboards you can use. This is an example from the AIM Center. This is an Excel dashboard that you can tweak. You can add new things to it if you want to, which I will show in just a minute. So right here, it's showing where the PHQ-9 scores are that you would look at during your individual clinical supervision and your team huddles and your team meetings. When it comes to transitions of care, we'll talk about some simple ones here, simple to measure, hard to do. Follow-up within 7 days of hospital discharge is a common one. Clients have been to the hospital to have at least one care transition meeting. Organizations that do this well monitor how that client got in the ED, into the hospital unit, and whether you spoke with the hospital staff or not. That's the care transition meeting. That's a really important metric to track. And if you've got hospitals that aren't willing to play ball with you, then you track the fact that you never spoke with them, but you tried. So measuring metrics like this can be really, really helpful. And as I mentioned before, your care transition metrics are going to be popping up in all your care pathways, because care transition is part of care coordination, which is part of the core of what you do, regardless of the illness, regardless of the social determinant need. There are a lot of other measures to pick from when it comes to care transitions. Some of them are described here, but I suggest that you pick the metric you're struggling with the most, or you pick the metric that you have access to, that you can begin this process of looking at data on a regular basis. The metric that's most commonly difficult to capture, most people got the follow-up within 7 days of hospital discharge. That's been kind of pounded into us as providers. This care transitions meeting is the one that's difficult to track, and it's something that you don't need a really complex EMR to do. You can do it by just dropping it into an Excel spreadsheet like the one I showed you for depression. This is the same spreadsheet from the AIM Center, and you can just drop in this metric. Now, if your EMR isn't capturing transitions of care, when do you capture the data? How do you put it in? Well, you could put it in during team meetings where you come together and you say Joe was hospitalized, and you say, well, did we talk to him before, while he was up on the unit, before we saw him today when he showed up in the waiting room with his My Belongings bag? And you can say yes and get credit for that, or say no. So there's very simple ways to track this if you've got a structured team-based care approach to delivering care. That's why team-based care is really coming out in healthcare as one of the most critical ways to improve efficiency and effectiveness for complex health conditions like the ones you guys treat. So let's do a quick poll. I'm just looking at the time.
You have about 10 minutes.
Yeah, we can do this.
We're good.
How many of you have access to care transitions data like we described? And by access, I mean it's actionable. You could, pull it today and meet with your team today. So it's either in your EMR or in another Excel spreadsheet database you've created.
So we'll just give you another 20 seconds to respond, and then we'll take a peek at the outcome.
Yep, and if you want to just quickly open the next poll too, just in the interest of time while we're looking at the data from the care transitions piece. These two questions are really critical, because if you're going to do transitions of care well, you need to know what it looks like when you've done it or haven't done it. And the only way to really know that is if you're tracking what's actually happening. Now, that doesn't assume that the hospital's playing ball with you and giving you data or talking with you, but it does assume that you as an agency, you as a team, are able to at least monitor what you're doing in relation to these other providers, and whether it's working or not. That presupposes too, which is the second poll here, whether you're doing team-based care, whether you're actually spending the time to meet, look at data, and do population health management. So is that second poll open now?
Yes, it is.
And what do we have for the first poll as far as people having data review?
It looked like 57% did and 43% did not.
Great. So for those 57%, it's a matter of using that data to inform your clinicians and your community partners that you're transitioning with as to whether it's going well or not. For the folks that don't, that's going to be one of the keys to developing a good care pathway, is to choose what metrics and then finding a way to pull those data, whether it be using an Excel database or getting your EMR folks on board with this. Without data, you're kind of blind. It's everybody's opinion as to what happened. And while opinion is valuable, opinion plus actual data showing what happened is more valuable. And let's wrap up the poll on team-based structure.
Jeff, I'm not sure if you can see the results, but in terms of folks that, okay, so in terms of folks that have a formal team-based structure, 41% said yes and 59% said no.
So for the 41% that are doing this and have data, you're probably experiencing a pretty useful regular set of meetings where you've got a lot more information to work with than you would without it. For folks that don't have data or don't have a team-based structure, really encourage you to consider looking at the team-based literature. If you go to the SAMHSA HRSA Center for Integrated Health Solutions, there were a couple innovation communities focused on team-based care where there's a ton of resources that can help you designing your huddles, your meetings, help with the job description piece. It's a process. Team-based care is hugely effective, but it's not an easy process to do well. It takes a little bit of time. So it's worth it to spend a little time looking at the literature around what works, what doesn't work, and then rolling it out along with your care pathway. So let's move on to the last 5 steps. Step 5, we've picked our metrics. Now we just need to look at what do we do based on evidence-based practice. If you're looking at a social determinant need, what do we do based on best practice for getting people employed or getting them housed? And critically here, this includes the crisis plan piece, which we talked about before. So for transitions of care, it's your crisis plan that's going to be really critical, because that's where the rubber meets the road as it relates to transitions of care for the hospital and for a lot of other providers. When it comes to helping someone, get housing or things like that, and you're treating depression, it's important to have that piece figured out too. As the person gets better, you're going to start to see some of these social determinant needs have transitions of care happening because the person's getting better. They're going to be stepping down to different levels of care. And it's often these transitions that happen when people are getting better that, if not managed well, can really get in the way. So mapping out, really looking at what evidence-based practices you provide, listing those out, and then mapping out your care pathway. As I mentioned, step 6 and 7 tend to be the biggest lift. And there's lots of ways to map your care pathway. I'll show you a couple. There's no right way to do this. I think the best way to do it is what you're able to do and what's most practical for you today. Some of you might have the time to do Lean Sigma and map out things the way I'm going to describe here in a moment. Some of you might not have any time to do that. So you're going to be mapping things out in your team meeting, or your supervisor is going to do the mapping themselves and then bring it to the staff to say, hey, is this how we do it? So when it comes to doing something like transitions of care, you're going to want to map out, how do we currently transition someone from the hospital to the community or from the community into the hospital. And write down those steps as to what it looks like. Write down who does what roles. Even get into how much time and the cost associated with those steps, because that'll really give you a good business perspective on what the cost of doing this kind of work is and whether you're getting paid for it or not. You can map things out in ways like this, which is a swim lane diagram. It's a Lean Sigma approach, where every person, whether that be the consumer, front desk staff person, is describing what they do in each step, and on the bottom here, describing what data they collect, how much they can bill for it, and how much the agency is paying for that person to do that step. And if you move from left to right and add up the time, add up all the data points, add up the cost, it gives you a nice business picture of what it looks like to treat someone with depression. When it comes to doing this with care transitions, and I'll just show you another slide here of other ways people have mapped out the treatment of depression. There's a lot of examples, and we can share with you different health conditions and how people have mapped them out. When it comes to transitions of care, however, you want to map that out too. And this is an example of how one agency mapped it out. And this was working with a hospital that was interested in measuring and tracking care transitions also. So on the top, you have the social worker at the hospital, and on the bottom lane there, you have the care manager or case manager at the community behavioral health center. And what they did was go ahead and map out what happens when someone shows up to the hospital. What does the hospital do? What does the behavioral health center do? And built into this are the specific steps people take and what's measured. So this is a really nice way to put in protocol form how you do care transitions. You can use it to train new staff. You can use it, importantly, to measure whether you and your partner organization are doing a good job or not. Developing the protocols is the next step, and this is one where people oftentimes get hung up because they get too detailed. Just bullet point out the steps when you're mapping it. Just do bullet points. It shouldn't be page after page of how you do stuff. Over time, you'll start adding information to that as you clean your care pathways and start tweaking them. But out of the gate, don't get too hung up in the perfection being the enemy of the good here. We're looking at simply laying out the steps that we've mapped and putting them to paper with bullet points. Exactly how do we transition people in and out of the hospital so that everybody's doing a brain dump and you're getting the perspectives of all the team members so you're getting an accurate picture of how it's done. The last couple steps, pilot that care pathway. So do the best you can in mapping it out. It doesn't have to be perfect. And then try it out for a couple months. Give it to the team that developed it, or if you're doing a big quality improvement process, you're going to need to train up another team to use whatever you created. But test it out. This is part of the plan, do, study, act. So the first 7 steps, you've done the plan. The do and the study are steps 8 and 9. So step 8 is the do. Try it out. See if it works. You came up with an agreement with the hospital around how you're going to measure these care transitions. Do it for 3 months and then come back together in step 9 and check and see, hey, did it work? Pull the data. Did we achieve what we set out to do? Step 10 is after step 9 is shown to be effective, you put it into standard operating protocol. And step 10 is, this is how you do your work. You put it into practice, and then every year at least, you should go back and look at your care pathways to see if there's a better way to do it, if it's working effectively or not. You need to have that regular data review to do your quality improvement checks. Population health management done by the team will be a constant check to your care pathways, because if people aren't getting better, or if those care transitions aren't working, it means you need to look at your care pathway and fix it. So step 10 is just that ongoing monitoring. Now I know we're pretty much at time.
Yeah, I was going to ask if you could forward to maybe the care coordination toolkit.
Yeah.
That's awesome.
So I'm available if you guys have questions coming out of this. I'm available, but this is a great resource that we suggest you take a look at that has a lot of sample information, whether that be a coordination agreement, whatever you need. It's pretty much been described here. I don't know, Nicole, if you want to mention more about this.
No, I think this is really great. And then if I'm going to just close out with the next slide if you're finished. I think that was awesome. Very informative as usual, Jeff. So thank you for that. And just a reminder, there are only two activities left of this series. So it's a webinar and then regional office hours. So please take a peek at the location, at your location, and familiarize yourself with the times and dates, and make sure that you get into those office hours. Jeff, I just want to thank you so much for a wonderful, informative webinar. Great to hear you speak. And there are no additional questions. Actually, the slides will be available. We have PDF slides that will be sent out after this webinar. And with that, I just want to thank everyone for being here and have a wonderful day.